Thank you for joining me again. Today we're going to talk about the pharmacokinetics of antiretroviral drugs. This is one area where I think pharmacists play an important role, especially with our knowledge base. This is where we can advise physicians, advise patients on the use of their medication. I'd like to start on the next slide, just reminding you of the currently available antiretroviral agents. And I have this, I'm going to start in a clockwise direction from my top left hand side. First you have the NRTIs, which I call the nukes, the NNRTIs, which I call the non-nukes, the fusion inhibitors, the CCR5 antagonists, the protease inhibitors, and I'll skip a bit and mention the integrate inhibitors. Right in the middle I have what I call the multi-class combination, where which are medications that are combined across the classes to uh, um, for efficacy and for ease of use. So you have a tripla, complera, and stribild. If you remember your basic pharmacokinetics, you will remember that it's just basically the way the medication moves across the body. So in pharmacokinetics, we'll talk about absorption, distribution, metabolism, and excretion. But I'd like to say that in this particular learning module, we will talk about the pharmacokinetic parameters that are of clinical significance. Of course, each of these drugs have their own parameters, but we will only discuss those ones that are of clinical significance. The first thing we'd like to talk about is absorption, and one of the things that we will know and remember is that the presence of food affects the absorption of a certain antiretroviral. For some of them, it's not just the presence but the type of food. So for efavirenz, taking efavirenz on a high-fat meal will increase the AUC by at about 50%. Now this comes to bearing when, especially in the early stages of therapy with efavirenz-based regimens, where the patients might be experiencing the CNS side effects of efavirenz. If patients are advised to take this medication at this time on an empty stomach, there's a likelihood that you might reduce the incidence of this side effect. On the other hand, when patients are advised to take it on a meal with a high fat content, then the AUC or the bioavailability will increase, and vice versa. Gastric pH is another thing that affects the absorption of a lot of medications, especially the protease inhibitors, indinavir and tazanavir. That is why we advise not to take these medications with antacids, proton pump inhibitors, or H2 blockers. The other thing about absorption is to also realize that certain physiological conditions might increase gastric emptying time, like changes that occur in pregnancy. This table indicates the medications that can be taken with or without food, and then refer to this table when you want to counsel your patients. This table tells us the medications that you may not crush. Often we have patients who are unable to swallow their tablets, and the question always arises whether they are allowed to crush, split, or even dissolve some of these tablets before they take it. There is not a lot of data on all of these medications, but there is a study that has indicated that the AUC of Calitra is decreased by 45% for the lopinavir and 47% for the ritonavir when they are crushed. So it is not recommended that you crush or dissolve Calitra before taking it. Raltegravir, on the other hand, crushing is not recommended. The granules are said to dissolve faster than intact tablets, and then this may affect the performance. The other thing is that the drug might have a bitter taste, and so the film coating helps to mask this bitter taste. So when you crush it, you destroy the film coating, and then maybe not be palatable to the patient. Efavirenz may be crushed, but bear in mind it is insoluble in water, so if you're crushing it, you have to mix it in an oil-based solution, and crushed tablets may give you a hot pepper sensation. You may crush or split tenofovir, but it does have a bitter taste, so you may want to mask that bitter taste in anything sweet. Um, there isn't a lot of data on this, but typically when these questions arise, I usually would call the manufacturers and find out what their recommendation is, if it's not in their package insert. Moving on to distribution, typically the changes in distribution or body composition that occur in the elderly, pregnant women, children, and malnourished patients may affect the bioavailability of medications. Pregnant women, you have to remember that their volume of distribution increases a lot, and so medications like Calitra are affected by these changes. For children, you know that their body fat composition is different from for adults, so is the elderly. The malnourished patients not only have changes in body fat composition, they also have changes in plasma proteins, like their albumin may be low, and that may affect medications that are protein bound. Talking about distribution, it is good to know which medications penetrate highly into the CNS. This comes to bearing when you have patients that are suffering from neurocognitive disorders or CNS disorders that are based on that are because of the HIV infection. Suffice it to say that things like medications like zidovudine and nevirapine and indinavir concentrate highly in the CNS, while medications like tenofovir surprisingly have a very low CNS penetration. There isn't any guideline talking about this or recommending this, but it would be wise to consider switching a patient on tenofovir-based regimen to maybe a zidovudine-based regimen if they're experiencing neurocognitive disorders. The other thing to consider is the penetration into the fetal compartment, which comes to bearing especially for patients who are for whom we're trying to have a mother-to-child transmission prevention. Suffice it to say that tenofovir and zidovudine concentrate highly in the fetal compartment. Tenofovir greater than zidovudine, and then maraviroc and enforvatide are least concentrated in the fetal compartment. And of course the PI is also ranked low in the fetal compartment penetration. Metabolism is one major consideration in antiretroviral agents. The P450 system is the main enzyme of metabolism. This is responsible for a lot of antiretroviral interactions. In fact, it's almost all of the medications are involved in P450 metabolism, except for the NRTIs, the nukes, and the raltegravir. This has been taken to advantage in some ways when we combine the PIs with ritonavir, or we now have the cobicistat, which is in the new pharmacokinetic enhancer. Cytochrome P453A4 is the main subset enzyme responsible for metabolism of antiretroviral agents. Like to draw your attention to the ones that are substrates of the cytochrome P453A4, and that will be efavirenz and protease inhibitors. And those are the medications that when patients are taken, we are very concerned about drug-drug interaction. I'd like to draw your attention to the pharmacogenetic predisposition of people of Asian and African descent. They have reduced efavirenz metabolism. This comes to bearing when we are co-administering efavirenz and rifampicin in patients who are HIV/TB co-infected. Unlike in most other patients, we can increase the efavirenz dose by 200 milligrams to account for the metabolism by rifampicin, but for people of African and Asian descent, the dose should remain unchanged because genetically they are predisposed or they are not predisposed to this metabolism. Moving on to excretion, the one thing to know is that the only medications that are mostly renally excreted will be the nukes, except abacavir and the integrase inhibitors. And so I would always check renal dosing for patients who are renally impaired for a lot of the nukes and then integrase inhibitors. The NRTIs or the non-nukes and PIs and abacavir are excreted hepatically. I'm providing a link for you to be able to check the renal and hepatic dosing for all of the antiretroviral medication. It's always important to check the renal dosing for all nukes, maybe except abacavir, and the hepatic dosing for all other medications, and this information is readily available at this website. Therapeutic drug monitoring is something that has been controversial, and in fact is not routinely recommended by most guidelines, but I thought it was something that we should mention in this learning module. It's not beneficial for patients who are on nukes, but we may find it helpful for patients who are on PIs and non-nukes. It's beneficial when we are having significant drug-drug interaction or drug-food interaction for patients for whom we can't change their therapy, or for patients who are experiencing GI, hepatic, or renal dysfunction. It's also useful in assessing blood levels in pregnant women or heavily pretreated patients who are experiencing virologic failure for whom we don't have a lot of treatment choices. It's also beneficial when we have using a dose combination or regimen for which we don't have evidence of efficacy, or when we're having concentration dependent drug associated toxicities, or when we are having lack of virologic response for patients who we are sure are medication adherent. So all in all, it's not routinely recommended, but I just thought we should discuss and mention it in this module. So finally, the issue of pharmacokinetics is one important area where pharmacists can lend their help or be of service to HIV patients. I believe that our perspective to HIV care is unique, and it's unique to us, and when we exploit it to the fullest, we are able to benefit the patient and the healthcare team. I'm open to any questions. You have my email address and you have my phone number, and please feel free to ask me any questions that you might have. Thank you.